I'm Dr. Austin Chen, an orthodontist from Vaughan, Ontario, coordinator and examiner for the RCDC in orthodontics, and staff orthodontist with the cleft lip and palate program at the Hospital for Sick Children in Toronto. Crowding is a disharmony between tooth size and alveolus size. It can be primary, where the cause is congenital, secondary, where the cause is a mutilation of the dentition due to environmental factors like tooth loss, or tertiary, when it's seen in adulthood. This is a case of primary crowding that is mostly characterized by the premature loss of the maxillary primary canines due to the eruption of the maxillary lateral incisors and mesial eruption of the first premolars. Additionally, there's a prior family history of significant crowding and is, in my opinion, an ideal case for serial extraction. Serial extraction is the early extraction of certain primary and permanent teeth at strategic moments in occlusal development, but it requires the ability to recognize departures from normal development and to predict growth changes with careful monitoring of the patient, study casts, and radiographs. The indications for serial extraction are primary severe crowding of 10 to 12 millimeters with no mutilation, a patient that is 7.5 to 10 years of age, maxillary and mandibular incisors that have a normal or proclined position, a shallow overbite or open bite tendency. Our young lady is the right age. The maxillary canines are completely blocked out. She has a shallow overbite with open bite tendency, class 2 molar occlusion, and her maxillary incisors are proclined. In this case, I would remove the remaining 6-4 followed by 1-4 and 2-4 as they erupted. This will decrease treatment time for crowding later in adolescence, prevent resorption of the roots of 1-2 and 2-2, and allow mid-alveolus eruption of 1-3 and 2-3 rather than having them erupt to the buccal or palate. For a more detailed discussion on the order of extraction in serial extraction cases, read the chapter on interceptive guidance of occlusion by Jack Dale in Graeber's book Orthodontic Current Principles and Techniques. Serial extraction is not without its risks, however. The child will likely require mechanotherapy, regardless of early intervention, and an argument can be made that aesthetics would be better if the first premolars were retained. The lips can upright the incisors, which can deepen the overbite, and a lower lingual arch is often required to hold the molars. Finally, if done in the wrong patient or at the wrong time, it can worsen a situation rather than help it. In this case, we can see that early intervention allowed the canines to find a channel for a normal eruption path. I'm Dr. Austin Chen from Vaughan Orthodontics. On behalf of JCDA Clinical Q&A, thank you to everyone who participates in the discussion.